Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have another Neurosurgical Super Sunday. We have a great lineup today. And today we have, we're starting off with Dr. Yang from Shanghai. She's going to introduce herself and describe her training and everything else. But first, let's go around the panel to introduce a diverse community of neurosurgeons. We'll start with you. Amir, how are you doing? Could you please introduce yourself? Hi, Amir. Could you please introduce yourself?
Good afternoon.
Yeah, good afternoon.
Oh, good afternoon. My name is Amir Badran. I'm Jordanian. I'm working as a head of neurosurgical department in Ukraine.
He's from the
Ukraine. Nice to meet you.
Nice to meet you.
He's from the Ukraine. Welcome. Andrea.
Hello, I'm Dr. Andrea Gerosa, and I'm a neurosurgical resident in Novara.
Very good. Welcome, Andrea. Duong, could you unmute yourself, please, and introduce yourself again?
Yeah. Hello, everybody. My name is Ian. I'm neurosurgeon of Vietnam. Thankful Hospital. Nice to meet all of you.
Duong, you might want to center your camera. We just see the bottom part of your face. There we go. Okay, Juma, welcome.
Yes, hello everyone. I'm Dr. Juma. I'm a neurosurgeon from Tanzania. It's my pleasure to be in the panel with Dr. Yang. He reminds me a lot of from China.
Very good. And Juma's currently in India now doing a rotation. Raphael, I guess Raphael just stepped away. Rakesh?
Hello. Hello.
Go ahead, Raphael.
Hello, this is Rafael Martinez Perez. I am a Spanish neurosurgeon for meniscal base and vascular neurosurgery. I'm currently in Valdivia in Chile.
Yeah, welcome, Raphael. And Rakesh, could you please introduce yourself?
Hello, everyone. I'm Dr. Rakesh AV. I'm from India. I am a neurosurgery resident and a proud part of neurosurgical TV since long time. Thank you so much, Dr. John and Dr. Yang, for inviting me here. Thank you so much.
Yeah, welcome. Okay, Dr. Yang, we have a diverse following for you today, and welcome. Could you please introduce yourself, tell it about where you're training, etc., and before you start your presentation, please, and welcome.
Okay, thank you. Good evening, everyone. So my name is Yang Zixiao from Department of Neurosurgery, Huashan Hospital. So I'm major in cerebral vascular and glioma. So it is my honor to be invited by the ACNS to share the topic, the application of revascularization in the treatment of intracranial aneurysm. So today, I will review several papers to give you a brief introduction of revascularization and also share our experience in the treatment of intracranial aneurysm from hybrid neurosurgery team of Huashan Hospital. So that's my introduction. Yeah.
Thank you. Okay, you're all set to start your presentation.
So may I start my presentation now?
Oop, we lost your sound there.
Oh,
what happened
maybe
there?
the link is not perfect. So is that
we
okay
lost
now?
Your sound. I don't know what happened. Hello?
Oh, wait a minute. Hello, I can hear you. Can you hear me? Oh.
Did you mute yourself or? We lost your sound there.
Can you hear me now?
I cannot hear. Cannot hear.
Just wait a minute, I will check. Wait a minute.
Okay, it's good. Okay.
So can you can hear me now? Yeah.
Yes, we can.
Oh, okay, thank you so much. Yeah.
Okay. Okay, all set.
So may I start my presentation now?
Yes, please.
Okay. So can you see my PPT now on the screen?
Yes. Yes.
Uh,
Excellent.
Yeah, so my topic is the application of revascularization in the treatment of intracranial aneurysm. So, surgical cerebral revascularization was first introduced by Professor Yasagyu in 1967, and during the past decades, technical and technological developments have considerably influenced the field. Conceptually, cerebral bypass surgery aims at augmentation or complete replacement of the blood flow to the brain provided by one cerebral artery. So technically, a large armamentarium of bypass strategies of intracranial aneurysm treatments has been developed and refined, many subdivided into extra to intracranial bypass, that is the ECIC bypass, and intra to intracranial bypass. So ECIC bypass is additionally categorized according to the amount of blood that it provides. So here is an illustration of ICIC bypass consists of reimplantation, reanastomosis, side-to-side anastomosis, and short interposition graft. Reimplantation uses an end-to-side anastomosis between the transected end of the afferent artery and the side of an adjacent donor artery. Reanastomosis requires trapping the aneurysm, completely detaching afferent and efferent arteries, and reconnecting cut ends to an end-to-end anastomosis. In situ bypass uses a side-to-side anastomosis between the afferent artery of the aneurysm and an adjacent parallel donor artery. It requires donor and recipient arteries that lie parallel and in close proximity to one another. So here are types of revascularization. As for the ECIC bypass, all three types of standard flow, intermediate flow, and high flow are shown with the provided blood flow and the common indication, as well as the typical technical variations. A standard flow bypass is a pedicled graft that usually provided 20 to 70 milliliter per minute. The most common example is an end-to-side anastomosis between the STA to MCA or the PCA. The next level of the flow provided through intermediate flow interposition graft using the radial artery as interposition graft with flow rates between the 60 and 100 milliliter per minute. Most commonly, this intermediate flow radial artery interposition bypass jumps from the proximal ECA to an M2 segment branch of the MCA. The highest level of flow is provided through a high flow bypass using a Zephyrus vein interposition graft with flow rate between 100 and 200 milliliter per minute. So bypass grafting for flow replacement remains the treatment of choice of complex aneurysm such as giant, partially thrombosed, or calcified, precoiled, or fusiform aneurysm that are not open to direct clipping, reconstruction, or endovascular treatment. So here are our technique and strategies experiments from Huashan Hospital published previously. Direct surgery for complex ICA aneurysm can be difficult. In certain situations, sacrificing the parent artery is an unique way to obliterate the aneurysm, and ECIC bypass is indispensable to prevent post-operative cerebral ischemia. During a 7-year period of 49 patients with complex ICA aneurysm underwent direct ICA sacrifice or ICA sacrifice combined with ECIC bypass. The appropriate type of bypass was determined by the result of a 30-minute balloon occlusion test and CTP, as shown in the figure of management algorithm for complex ICA aneurysm. People who tolerate the 30-minute BOT without developing neurologic deficit were identified. If they additionally had less than 0.5 second delay during the capillary phase in the ipsilateral hemisphere with contralateral IC angiography, as well as having the MTT, CBF, and CBV manifesting no hypoperfusion as determined by CTP, they were treated by ICA sacrifice without the ECIC bypass. People who didn't tolerate the BOT were treated by ICA sacrifice and the ECIC bypass. The technique of ICA sacrifice used was selected based on the evaluation of retrograde filling of the aneurysm during the blue occlusion test. If the retrograde filling to the aneurysm was detected during the BOT, we performed ICA trapping on both sides of the aneurysmal orifice. We draw the conclusion that balloon occlusion test combined with CTP can be an efficient way to evaluate the compromised cerebral vascular reserve in patients with complex IC aneurysm. So, furthermore, we preferred STA-RA-MCA bypass followed by prolonged ICA occlusion in older patients or in those whose BOT result was minor positive, which means no cerebral ischemia manifestation, but the capillary period at ipsilateral hemisphere delayed more than 0.5 seconds. As shown, we believe that ECA-RA-MCA bypass is also suitable for minor positive patients. However, STA-RA-MCA has some advantages. First, it is performed easily and no additional cervical skin incision needs to be made. Second, the RA graft of only about 10 centimeters is needed. Third, the STA to RA to MCA bypass also could provide sufficient blood flow after ICA sacrifice. Most vascular neurosurgeons advocate high-flow IC bypass before sacrificing a main intracranial artery like the ICA. Technically, a vessel graft such as a radial artery or saphenous vein can be used for revascularization. In this series of cases, we recommended radial artery graft for revascularization. The radial artery lumen caliber closely approximates that of the MCA, M2, or M3 segments. The RA graft has several advantages. Harvesting RA is easier. The lumen caliber closely matches the recipient vessel. The RA has lower incidence of graft failure, and it has superior reliability for long-term patency. The main disadvantages of RAG is the possibility of occurrence of spasm. To reduce or eliminate this effect, we have routinely used the pressure distension technique during the procedure. Because of the diversity of aneurysm morphology, completed arterial anatomy, and hemodynamic characteristics, tailored surgical treatment are required for cases for individual complex MCA aneurysm. So the surgical modality and strategy for treating complex MCA aneurysm are decided according to the morphology of aneurysm, the vascular anatomy, and the hemodynamic characteristics of each case. Thus, we developed a new classification of the complex MCA aneurysm into three main types based on the angial architecture. The main difficulty in treating aneurysm originated from M1 segment is preserving the lenticular striant perforators, which are often incorporated into the aneurysm base or dome. We use an STA to RA to MCA bypass to treat the patients. In treating aneurysm originated from the M2 segment or MCA bifurcation cases, if sacrifice of the parent artery was necessary to obliterate the aneurysm, an arterial reconstruction such as an STA-RA-M3 or intracranial M3-M3 bypass should be conducted before the aneurysm is trapped. Then, for aneurysm which originated from the M3 or greater distal segments, obliteration of the aneurysm with parent artery sacrifice is tolerable in most cases. Ulteriorly, an investigation published in JNS proposed a comprehensive and flexible algorithm based on MCA aneurysm location for selecting the best of multiple bypass options. The bypass strategy used for an MCA aneurysm depends on the aneurysm location, the RSA anatomy, and the rupture status. Illustration showed aneurysms of the MCA, which were classified according to their location relative to the MCA bifurcation as pre-bifurcation, bifurcation, or post-bifurcation aneurysm, as seen from an anterior oblique view with the frontal lobe sectioned down to insular. Then the post-bifurcation aneurysm were located in a sylvian fissure, insular recess, or opercular. So that is the classification. The management of pre-bifurcation MCA aneurysms was dictated by the presence or absence of LSAs along the aneurysmal segment. Bifurcation MCA aneurysms was determined by their rupture status. Those aneurysms in patients who present with SAH must be excluded completely, and when conventional clipping failed, the aneurysm is trapped and multiple trunks are revascularized. The strategy for post-bifurcation MCA aneurysm is determined by their location along the MCA circulation. MCA bypasses was classified as one of 7 types. The EC-IC bypasses consist of the low flow and the high flow bypass, and then the IC-IC bypass involve an IC donor artery and one or more of the following reconstructive anastomosis, such as reanastomosis, in situ bypass, reimplantation, interpositional bypass, and combined bypass. Preferred choice for bypass options for each aneurysm type was demonstrated. For pre-bifurcation and post-bifurcation aneurysm in sylvian and opercular, the preferred options are reanastomosis. So for bifurcation aneurysm, the recommended option is combination bypass, while for post-bifurcation aneurysm in insular, the best choice is the EC-IC bypass. To better understand the IC-IC bypass techniques for MCA aneurysm, figures show the overview MCA anatomy and several bypass types. The Fig B is an in situ bypass of ATA to MCA. The Fig C shows the reanastomosis of MCA. Then is the reimplantation of MCA to MCA and the intracranial bypass graft of ACA to MCA double reimplantation. A paper published in Neurosurgery provided the possibility of maxillary artery to MCA bypass. A schematic drawing showing the segments of maxillary artery and their relationship to bone structures. Then the anterior cerebral artery aneurysm requiring bypass are rare and can be revascularized in a variety of ways. More than any other aneurysms, it requires a thorough survey of patient-specific anatomy and microsurgery options before deciding on an individual management strategy. The author's experience demonstrated a preference for ICIC reconstruction bypass. So here are illustrations of ICIC bypass techniques in ACA aneurysm. The fig B showed the in situ bypass of A3 to A3, and fig C demonstrated re-anastomosis of ACA. Fig D is reimplantation, and fig E showed the intracranial bypass graft of ACA double implantation. Commonly, most current bypass paradigms of complex ACA aneurysm recommend technically demanding side-to-side anastomosis or use of interposition grafts, which involves longer ischemia times. So then a recent study suggested that ATA to ACA bypass is anatomically feasible and may be a useful alternative to other revascularization technique. It is technically simpler than A3 to A3 in situ bypass. The ATA-ACA bypass can be performed through the same exposure used for the ACA aneurysm, sparing the patient an additional approach. Then as for pica aneurysm, selection of the bypass technique was influenced by the aneurysm's location according to pica segments. The bypass options include the in situ bypass with P3 to P3 pica to pica bypass, in reimplantation of the pica to the proximal V4 segment of the VA, the pica reanastomosis after aneurysm excision, and high-flow bypass from the V3 segment of the VA to pica with radial artery interposition graft. The selection of pica bypass is almost algorithmic. The pica to pica bypass can be used for pica aneurysm on any segments except the P4 and is perhaps the most versatile. Reanastomosis can be used with pica aneurysm beyond the P1 segment. Due to its depth, proximity to lower cranial nerves, increased morbidity, and decreased patency, reimplantation is reserved as an alternative when these bypass options are unfavorable. Interposition grafts are rarely needed for pica aneurysm. A constructive approach that preserves the pica with direct clipping or replaces flow with a bypass when sacrifice should remain an alternative to the constructive pica occlusion and endovascular coiling. As for basilar artery apex aneurysm, algorithm showed the IC to IC bypass techniques. The IC to IC bypass for B aneurysm, including in situ bypass of SCA to PCA, reanastomosis of PCA, reimplantation of ATA to SCA, and intracranial bypass graft of VA to SCA bypass, and also intracranial bypass of middle cerebral artery to PCA bypass. Posterior circulation bypass surgery has been used to treat many cranial pathological conditions, such as ischemia neurological disease, skull-based tumors involving the VA and its branches, and also complex and giant intracranial aneurysm. The possibility of the occipital artery for posterior circulation bypass was also raised. The bypass from the OA to the caudal loop of the pica demonstrates the least difference in vessel diameter and is therefore best suited for the ECIC bypass procedure in the posterior circulation. The OA pica bypass was performed when the pica was compromised by the obliteration of the VA or pica aneurysm. Furthermore, the caudal loop of the pica, which is a portion of the tonsil medullary segment, is generally considered to be the optimal site for OA pica anastomosis. The absence of the caudal loop of the pica is a major contributing factor to the technical difficulty of this OA to pica bypass. The far lateral approach is a useful surgical option for OA to pica bypass when the caudal loop of the pica is unavailable. So, in summary, the cerebral bypass surgery aims at augmentation or complete replacement of blood flow to the brain, and surgical strategies require a survey of patient anatomy. Our technique and strategy from Huashan Hospital are shown here. It can be divided into the pre-operation evaluation, intra-operation techniques, and post-operation treatment. For pre-operation evaluation, we mainly concern about aneurysm angioarchitecture analysis and hemodynamic evaluation, including BOT and CT perfusion, SPECT and PET, to help make aneurysm bypass strategy. Also, before harvesting RA graft, bilateral island tests are necessary. Intraoperation techniques include temporal clip, parent artery occlusion, and low intraaneurysm pressure. After operation, the treatment of nimodipine and aspirin, and also maintenance of blood volume should be taken care. So that's my topic, and thanks for my tutor, Professor Moore, and the guidance of Professor Zhu. Also, thanks a lot for the invitation from Professor Xu and Professor Yako Kato. Also, thanks for your attention.
Okay, very good. Thank you very much. Excellent presentation. Let me get back here on the screen here, coordinate things. We have a very diverse group here. Let me introduce Margarita. You didn't meet Margarita before. Welcome, Margarita. You're muted, Margarita. Hold on. Margarita, could you please introduce yourself?
Good morning. My name is Margarita Conceição. I'm a neurosurgeon from Brazil. Congratulations. It was an amazing presentation. I came a little bit late, but it was very, very good. I want to you talk a little bit about how many cases do you have. If you have explained it yet, please, I'm so sorry. Can you repeat again, because it's a very interesting topic.
Very good. Okay, I'd like to introduce, why don't you take over? Why don't you moderate from here? We have a great group of neurosurgeons here right now, and Dr. Yang just finished her presentation. So, could you please introduce yourself to Dr. Yang?
Hi there. What did Yang talk on?
Okay, could you please introduce yourself, Dr. Yang, and the rest of the group?
Can you hear me?
Yes, we can.
Okay. Yeah, I'm Dr. Cherian. I'm a vascular and skull-based neurosurgeon. This is Ahmed. Ahmed is from Yemen, and he is my fellow at Biratnagar in my center right now. And I believe Dr. Yang talked on cerebral revascularization in giant aneurysms.
Yes.
Okay. Yeah, great. I mean, I could not get the link till now. We just got the link right now, so we could get in right now. So I'm sure it's a very interesting topic, and we have a good experience of over 10 years I try to avoid revascularization whenever I can, but of course, in giant aneurysms, we always do an insurance bypass between ST and M3 or M4 branches. And if needed, we do a high flow bypass if we are sure that we need to compromise the vessel. But otherwise, we often get away with just ST to M3 bypass. And in fact, my fellow, he would be talking about how he learned and he is now doing good bypasses in the lab right now. So we have a lab where my fellows can do the bypass before they graduate onto the rats and then to the theater. So he'll be, in fact, other than talking about the last 2 days cases, that's one cranio and a giant CPA angle, he will also be talking about his experience in the lab where he started doing bypasses, and he will be showing as to where he has reached. So, I mean, I'm sure I have been to Huashan and when Shaoliang Fu was the chief, and I know Binzu very well, and I know Ying Mao also. He's my good friend. I have been to China many times. In fact, I've been to China more than 15 times. So I have been to Nanjing many times before, and in China we have a huge group of people who does cystonostomy. In fact, I mean, I have come and operated in China also. So my regards to Binsu and to Ying Mao, and if Shaoliang Fu is there, my regards to him as well. So yes, so I think we will be okay with the next topic. It's Vignesh is here.
Okay, we're just going to get some comments from the certain neurosurgeons that just watched the presentation, okay, before we go on. Okay, any comments or questions of Dr. Yang from the other neurosurgeons? We have a good group of neurosurgeons today. Any other comments and questions? Raphael, Margarita, you've already talked. Juma, Amir, Andrea.
Please, can you send me your email for contact, please?
Yes, we'll get you in contact with Dr. Yang.
Okay.
Okay, Raphael, you're a vascular man. Do you have any questions or comments?
Well,
and I want you to meet Ipe and the rest of the guys too.
Thank you so much for sharing your experience, Dr. Yang. I also was recently impressed by Professor Chu last week when he presented in Italy, and I was so impressed about the numbers that you have and the wide experience that you have there back in China. I really appreciate your presentation in complex aneurysm, but I'm very interested in it could be a possible topic in the upcoming weeks regarding the chronic ischemia and the indication you have there in China or in your in the experience with your professor there in China. What do you think? Do you think that could be a nice topic to talk about?
Sure, it sounds good. Do you want to give it, Raphael, or you?
Well, I'm very interested in see what the people from China.
Oh, okay, yeah, great. If Dr. Yang does a great job, we'd love to do it. Do you think you could get someone to do that topic, Dr. Yang? Did you hear what Raphael said about the topic for possibly next week?
Yes, sorry, I need a pardon about.
We'll talk about that later, Raphael. We'll try to arrange that later. Okay.
Cool. Great.
Okay. Any other questions or comments? Duong, Andreas, Amur, Shumo, a lot of guys here, right, today.
Hello, Dr. John. I have a question.
Yes, go ahead.
So I just wanted to ask the presenter, Dr. Yang. It was a very nice presentation. I just wanted to ask how many revascular surgeries have you done, and what was the complex one you have performed so far?
Oh, because I'm just finished. I have just graduated for 2 years and now in a general surgery treatment. So for me, myself, I didn't do so much bypass on human, but we practice on rat. So for our hospital, that a paper published show that in 7 years we had 40. I remember it's 49 MCA bypass and also almost 50 IC bypass. So it is, I think it is a very useful surgery strategies in complex aneurysm. And also because the Huashan Hospital is a center in the South China, so many patients of the complex aneurysm, they come from a different province. So we have the number. Yeah.
Thank you. Thank you so much.
Okay.
Yeah, I mean, I have a comment, John.
Go ahead.
One of the things that it interests me is that you have on one side a guy like Yuha who never does bypasses for any aneurysms. And then when you have another group where bypass is a very common thing. Now, both of them need not be necessarily right. So what my experience is with an insurance bypass, which is not very difficult actually, which is, no bypass is really difficult if you're trained for it. But with an insurance bypass, without much ischemia, you can usually reconstruct. Even MC, I have many videos of this. I'd be happy to show this. You could reconstruct. I mean, when Andrea was here, I remember that we had 2 giant aneurysms. We reconstructed the ACOM without any bypass. Do you remember that, Andrea?
Yes, yes, of course.
Yes, so we had a giant ACOM. I mean, and I thought I might have to do, Andrea was here probably for 2 weeks, but then we have many, many videos of these giant aneurysms where we really didn't have to do a bypass. We could reconstruct it beautifully without any problems. So bypass, and if you know skull-base techniques, many of these giant IC aneurysms may really not need, if you can do a transcavernous approach, many of these aneurysms would not really need bypasses. But yes, an insurance bypass is very essential. So in the future, my point is you should be able to combine skull-base with vascular. And if you can do that, and if you also have the bypass ability, this would be a complete vascular setup. I mean, this would be better than the endovascular guys on any day. And this is what somebody who's trying to become an aspiring vascular surgeon should do. She should have a good knowledge of skull base, a good knowledge of vascular, and working knowledge of bypass. That said, basilars, most basilars for sure, I mean, they would go into the endovascular hands because for us, even with a lot of experience, basilars are a difficult proposition. Not that it is extremely difficult or it's undoable or something, but it's easier for the endovascular guys to do it. So, I mean, it's a very welcome venture that Jan has been presenting this bypass, and I hope all the vascular surgeons start taking it up.
Okay, any comments or questions, Duong or Amur?
Thank you so much, Dr. Aib, for your input. Thank you so much.
Okay, thank you, Prakash.
Actually,
go ahead, Andrew.
If I may say, if I can say something, I think in the future, with the hybrid team and the endovascular surgeons developing new techniques, I think bypasses are essentials for vascular neurosurgeon. Probably because, in my opinion, many aneurysm will be treated by the endovascular team, and only the giant aneurysms and the difficult ones will be treated by surgery. So I think it is very important to develop these kind of techniques.
Okay. Okay, very good. Okay, very good. Let me make sure. Okay, I guess Juma, do you have any comments or questions, or Amr, do you have any questions or comments for Dr. Yang?
I want to tell Mr. Yang, thanks for this wonderful and amazing presentation. I wish you a career growth. Thank you.
Thank you, Amr. Juma, do you have any comments or questions before we close here with Dr. Yang?
No, it's just a nice presentation.
Well,
thank you
Juma,
so much.
maybe have stepped away. Okay, well, I have a general question. I'm not a neurosurgeon, and maybe Iper or anybody can answer this question. Now, there's a different approach basically to aneurysms in different countries. Can any of your neurosurgeons comment on that? It's different from China. It's different from India, the United States. There are different approaches, different philosophies. Ipe could... Oh, Ipe, you're on mute. You're on mute, Ipe. You're on mute, Ipe.
Yeah, can I be audible now?
Go ahead, go ahead.
Yes.
Okay, so the purpose of any aneurysm surgeon, whether it's endovascular or it's open, is to obliterate the aneurysm. Now, how that can be done, obliterate the aneurysm and save the parent vessel. This is the purpose. Now, how that can be done, whether it's pushing coils into it or clipping it, or to save the vessel to put in a bypass, this depends on the finances of the country. For example, in a place like Nepal, we don't have endovascular at all because nobody can afford it. It's very simple. Nobody can afford it. I mean, in my center, we have a cath lab too, but nobody can afford coils or embolization. So I have to clip everything. Now, depends also on the surgeon. For me, I believe that there is no aneurysm which I cannot clip or bypass. So I believe so. So, and you have believes the same. So I mean, in my last 10 years, I have never come across an aneurysm which cannot be clipped or bypassed or together. So now there are many endovascular guys who believe the same thing. So it depends on the surgeon's expertise. It depends on the finances. There are these different philosophies, but that said, we classify aneurysm surgeries into A2+, which means the A procedure is like an ACOM aneurysm. Complex aneurysms, which doesn't require bypasses, I classify it as A+. With bypass, it's A2+. And A2+, the beauty of this thing is A2+ procedures takes about 10 years for the surgeon to master. Anybody. So if you practice properly, it takes 10 years for you to master. So, and that is if you are every day in the lab. I mean, I am every day. Ahmed knows. We are every day. Me and my wife, we go every day to the lab. I mean, my team goes every day to the lab. Every day we practice on chicken wing. Every day we anastomose. And if we don't anastomose for 1 month, that's lost. The practice is lost. So A2+, it's an A2+ procedure. Now, for an endovascular surgeon, after doing 3 years or 4 years of endovascular surgery, these guys are ready to take on literally anything. So there is a difference in a learning curve here. So it's not as easy as for the surgeon. But once he reaches that level where he thinks that he can do anything, I mean, it's different for different people. But once he reaches that level, he's comfortable doing anything. So any aneurysm is not going to deter those kind of surgeons. So the important thing is to reach that level. And then you can say that, okay, fine, my philosophy is this. But what is happening in Europe and many other places is that people are taking up different things. I mean, now there are people saying that the endovascular surgeons should clip also. The neurosurgeons should do endovascular and clip also. This is nonsense because I believe the guys who are doing both will not be good at both. I mean, this is a totally different set of skills. Although I have a lot of guys who say that, no, the neurosurgeon should be doing this both. You do both. Your easier thing to do is the endovascular. So whenever you have an aneurysm, you have a choice. So you will, your choice will always lead you to the endovascular. So your clipping skills are going down the way. I know many guys will not agree to this, but I have no choice. I don't know how to do an endovascular procedure. So I will always clip, and I'm pretty good at it. I mean, I'm not being arrogant at it, but I'm pretty good at it. I can clip anything. So the philosophies, the attitude, the confidence, finances, all these are factors. So many people have different views. My view is not entirely correct, perhaps. Maybe, China, their view is more correct, or Europe, their view is more correct. We don't know. So I hope that answers your question, John.
Okay, thank you. Thank you, Wipe. Okay, any other closing comments or remark? Go ahead, Rakesh.
Thank you so much, Dr. Ipe. I really feel it's a great honor to be in a panel where great people like Dr. Ipe is there. And when I listen to his confidence that I can clip anything, I know what practice it's been. So I would be grateful if I work with Dr. Ipe. Someday I could see his dedication and the way he says every day he spent in the lab at this age with this experience, and that makes him to say I can clip anything. I am really grateful to be in the panel where Dr. Ipe is speaking. Thank you so much.
Well, Nepal is not far from where you're at, Rakesh.
Yeah, I'll be there for sure.
Go ahead, Raphael. You have a comment or question? You're muted, Raphael. You're muted. Unmute. Yeah, just unmute to yourself there. There you go. Okay.
Yeah, I know.
Yes.
Okay. Thank you, Dr. Sherian, for your comments. I completely agree regarding among my experience through Europe and Canada and now in Chile. I realized that it's very difficult for a young neurosurgeon to form in open vascular neurosurgery, since most of 90%, and in some centers, 100% of the aneurysm are treated by coil. When you are neurosurgeon on training, especially in Spain, you don't have access in many places to the endovascular room. So you don't really know what happened in the OR, and you don't really know what happened in the endovascular room, which is a big problem for what we can call developed countries. I think that this problem is also rising in the U.S. I don't really know what's the field there, but I think that's a problem that it's coming up in all developed countries in the North Hemisphere. It's impossible to treat an aneurysm by a young neurosurgeon. And if any MCA complex aneurysm needs to be treated, is one option is treated by a senior guy, which could be in his 60s, because he's the only one who has experience, or is not treated at all, because endovascular cannot do it, and young neurosurgeon never seen one. So that's a big problem. That was my reason to move to Chile to learn with Dr. Mura. I also had the chance to perform a fellowship in London, Canada, and I not 100% agree in the other fact that Dr. Sherian comment that, I mean, a dual neurosurgeon is not a good combination, in terms that you do one procedure, you are not gonna be as good in both, because you have to choose, right? From my perspective, I'm the only vascular guy now in Valdivia, in the place that I'm right now. But in my hands, I really know which the procedure I'm more comfortable. That's right. But at the same time, I know which is the best chances of having the better option for my patient. I think it's very important to have a good training on both. And if you don't have a good training in open vascular, so then don't do it. Try to look for special vascular neurosurgeon who can do those procedures, and always choose the procedure that you can do. And I mean, that's my recommendation, but I think we have a problem right now. Also, the trend towards the endovascular neurosurgery brought in the 90s after the ISAT study, which everybody knows that's a highly biased study, but that changed the trend from open vascular to endovascular. So now we are the numbers that the learning curve is going to be more difficult to achieve. See, we are not going to have enough procedures to master the technique. So Dr. Cherian has much more experience in teaching and training with all his fellows, and also Dr. Mura is the one who I was training by. They can tell us more about this, but I think that it's now in these countries, in South America, in India, in China, where we are going to find the vascular neurosurgeon, and I think, guys, in some point we have to take over in that sense.
Very good. Do you have anything to say, Ip, about Raphael's comments?
Yeah, Raphael, first of all, my regards to Yohei Miura. We used to teach together 6 years back in Salim's courses in Missouri, in United States. Yohei is a fun guy to be with. So I haven't seen him after that, so my regards to him, number one. Number two, I believe this ISAT, and now the most recent study on AVMs is completely crap. It's a nonsense study. Okay, it's done by aneurysm surgeons who have no bloody idea of how to clip an aneurysm. So when you compare somebody who doesn't know how to clip an aneurysm with a good coiler, of course you're not going to get good results. So I mean the AVM study, which is stupid, actually, completely stupid. I mean, yesterday Ahmed saw us excising another AVM. We have, I mean, not all grade 5s, but some of the grade 5s we have excised and we have published it also. And grade 3, we routinely excise. We had a grade 3 day before yesterday. We excised this AVM without any problem. The patient is out of ICU and going to be discharged right now. So the point is, these surgeries require 10 years of experience. And 10 years of experience without a choice of an endovascular guy. This endovascular thing has put a choice, and now they're talking about complete embolizations of AVM. I don't understand this. I do not believe this, first of all. And if you have a choice, you are never going to be good in these surgeries. For sure, if you do just one AVM a month, you are never going to be a good surgeon till you are in your 60s, for sure. And if you have enough AVMs and aneurysms, slowly, in 10 years, you will become good. Where you can excise these AVMs with confidence, where you can clip these aneurysms with confidence. But unfortunately, Europe and many places have a choice, which should not be there. That's what I'm telling you. I mean, maybe in these countries, this developing, so-called developing countries, where you don't have a choice, you will have very good surgeons. Like I'm sure Yohei Miura, when he was doing his aneurysms, he didn't have a choice. If there was a choice, then everything will be coiled. So then he wouldn't get to clip anything. Then he wouldn't get to bypass anything. Only aneurysms which are not coilable, and they are almost unclippable also. And a guy who's doing 10 aneurysms a year, how are you expected to clip an aneurysm which is cannot be coiled? It's impossible. So I think we have to start. Looking to the east, where you look at China, you look at India, where people are clipping a lot, and we tap into their experience. And you know, groups like this, we share. Neurosurgeons share. What is your frank opinion on this? And then we show our surgeries, and that's the only way to learn. I mean, I also have to learn a lot, I'm sure. I'm sure everybody has their own bag of tricks. And we put it together, and that's when the young residents, and we should have fellows. Like you have had his fellows in Helsinki. Binzu should have his fellows in Shanghai. Maybe Yang should facilitate that they should have fellows there also to learn. And maybe some good surgeons in India or Latin America, where somebody is doing excellent aneurysm surgeries, they should focus on these people and then bring up the aneurysm standards, clipping standards to very good. Instead of that, if you do a trial with a guy who's doing 10 aneurysms a year, it's always going to be a failure for sure. It's going to be a big failure they will even ban open surgery, I'm sure. Because these are guys who doesn't understand the basics of aneurysm surgery. So, I mean, I'm sorry to say, but in the UK, the standard of aneurysm surgery is not, I mean, I wouldn't do an aneurysm. If I had an aneurysm, I wouldn't go to UK. That is for sure. So I would rather do it with my residents than go to UK. So sorry to say that, because everybody is spoiling it. And the guys who are clipping are doing 10 a year, which is very sad. And they shouldn't be even talking about open aneurysm surgery. We do that much in a good week. If we have a good week, we do 10. So, yeah. So we shouldn't be comparing these kind of people. So as Raphael said, yeah, I mean, we should be looking at places where specialist neurovascular, where a lot of volumes are there, and then we should be focusing on these centers to teach and share the knowledge. Like Fudan, Huashan is one of the largest hospitals in the world. I believe they have 10,000 cases a year. So, I mean, and when I went to talk to Shaoliang, and in fact, China, many centers, I have seen Shanghai, Beijing Tiantian. I have been to Beijing Tiantian also. The vascular surgeon is a good friend. And these guys have 10,000 cases a year. These guys should be leading people in, and Russia, the federal neurosurgical centers in Russia also, like the Burdenko or Albert Center, they have massive caseloads. So, and excellent surgeons. So these guys should be leading, these guys should be sharing, and then we will have some future for aneurysm surgery. We are not dead. We are not extinct.
Thank you so much for your comments and encouragement. Yeah. So.
Very, very good. Okay, we have to wrap this up, Dr. Yang. Thank you very much, and thanks to all the neurosurgeons for your interaction.
Just one more
go ahead.
Okay. For the previous questions, so I have several comments. So for the endovascular and open vascular surgery, I think the situation in China is similar. So because if the aneurysm can be coiled or can be both coiled and clipping, if you give the operation, if you give the option to the patients, most patients in China will choose the coiling. So the second, because the training time of the endovascular specialist is much shorter than the neurosurgeon. So in some area of China, that most neurosurgeons, they are endovascular neurosurgeons. So the patients in that that areas, they will review the endovascular treatment. But now in Huashan Hospital, we are doing one thing, that we want to build a dynamic cooperation of neurosurgery, the open neurosurgeons and also the endovascular specialists, and we use the hybrid operation room. So this is a team. They have the professors from different aspects, so that for each case, that the specialists from each aspect, they will debate and have one better solution for the patients. So I think maybe for the complex aneurysm, the tendency is the hybrid operation room in China. So thank you.
Thank you very much, Dr. Yang. Okay, we're going to start the next presentation with Dr. Kumar on vascular encasements in skull base meningioma. I'd like to thank you, Dr. Yang, and the next speaker is going to take your seat, if you don't mind. Thank you very much. We'll see you at more presentations, okay?
Yeah, see you.
Okay, bye-bye.
Bye.
And everyone else can sit tight. We're going to start with Dr. Kumar. He's going to come in. Let me get there. Okay. Okay, you need to exit, Dr. Yang, for the next speaker, please. Okay. Okay, you can exit, Dr. Yang. How can I diplomatically do this? Yeah, you just need to exit, please. You have a limit on the number of people on it. Google Hangouts. There you go. Well, no, that's okay. You don't have to. Okay, you can stay there. Someone left. Oh, two people left. So you can stay, Doctor. Everyone left at the same time. Okay. Okay, Dr. Kumar's going to come in. Raphael, I'm glad you're here, man. You get to meet all these people.
Sorry for so many times I missed. Sorry.
Yeah, I know you're a busy guy. I understand the life of neurosurgeon. I understand.
Now I gotta go to a wedding, so it's difficult on weekends.
Oh yeah, I know you guys don't have much free time. I know that. I know that. Believe me. Okay, welcome, Dr. Kumar, and I guess we can start the presentation whenever you're ready. But first, I want you to meet the rest of the neurosurgeons that are here, because one of the values of this platform is meeting, networking with other neurosurgeons. Amira, could you please introduce yourself to Dr. Kumar, please?
Good evening. Good evening.
Hold on, Dr. Kumar. They're going to introduce. They're going to meet you first. Go ahead, Amir.
Good morning. Good evening, Mr. Robert.
Good evening. Good evening.
My name is Amir. I'm a neurosurgeon. I'm glad to see your presentation and listen to you. So thank you.
Yeah, Amir's from Jordan. He's currently in the Ukraine. Andrea, could you please introduce yourself to Dr. Kumar?
Hello, I'm Dr. Andrea Gerosa, and I'm a third-year resident in neurosurgery in Italy, currently in Novara near Milan.
Welcome, Andrea. Juma, I don't know if you're there now. Are you there, Juma? Can you hear me okay?
Yes, I can hear you. Hello, everyone. I'm Dr.
Go ahead, Juma. Introduce yourself, please.
Can you hear me now?
Hello. Go ahead.
Hello, everyone. Hi.
Oh, I guess we're having some connection problems. Okay, Margarita, could you please introduce yourself to Dr. Kumar?
Hi, good evening, from Margarita. I'm a neurosurgeon.
Hello, good evening.
Okay, very good. Okay, Juma, are you there now?
Yeah, yes, I am here.
No, hold on, Dr. Kumar. Juma, are you there now?
Yeah.
Yes, I'm here.
Can I start my presentation?
No, hold on, Dr. Kumar. We're just trying to get all the introductions here. It's a little unwieldy. We can't hear you, Juma. I guess we'll come back. And you're muted. I don't know. I can't hear you at all. I think your microphone has a problem. Yeah. Can't hear you, Juma. Okay, anyways, Juma is a neurosurgeon from Tanzania. He's now in India. I think he's in New Delhi doing rotation. Raphael, could you please introduce yourself to Dr. Kumar from India, please?
Hello, Dr. Kumar. This is Rafael Martinez Perez. I'm a Spanish neurosurgeon specializing in skull-base and vascular neurosurgery. I'm currently in Chile.
Welcome, and welcome, Mix, to the Hangout. Okay, Rakesh, could you please introduce yourself?
Yeah, I'm here.
Hello.
No, hold on, Dr. Kumar. Rakesh?
Yeah, hello, Dr. Rupesh. This is Dr. Rakesh from Kolkata, India. I had a pleasure to meet you in one of the conferences in JIPMER when you were consultant in JIPMER in 2014. I attended annual skull-base surgery, annual skull-base neurosurgery. I had met you there. It's nice to see you, sir. Thank you so much. Thank you so much.
Yeah.
Thank you.
Very good. Dr. Kumar, could you please introduce yourself first before you start your presentation? Dr. Kumar, can you hear me okay?
Yeah, I'm hearing you.
Okay.
Thank you. Yeah. Can I start my presentation?
Yes, just a brief introduction of yourself, please, your work, where you're at now, etc.
Yeah, I am Dr. Rupesh Kumar. I am from Chennai. Yeah, I'm hearing. Yeah, I am from Chennai, India.
Okay.
I am in Chennai.
Okay. And where do you work, Dr. Rupesh, Dr. Kumar?
Yeah. So I am interested in cerebrovascular surgery and skull-base surgery. Are you hearing me?
Yes, we can hear you. Yes, I can hear you.
SRM Institute of Medical Sciences, SIMS Hospitals, Chennai.
Okay. And I understand you established the Department of Neurosurgery at your hospital. Is that correct?
Yeah. So are you able to see the screen presentation?
Yes, I can. We can.
Yeah, that is right. That is right. So can I start my presentation?
Sure.
Yeah. So are you able to see the screen?
Yes, we are.
Yeah. So I would today speak on arterial encasement in skull-base meningiomas. So I would today speak on arterial encasement in skull-base meningiomas. So in skull base, the arteries can be either encased or engulfed, and that depends on the arachnoid plane. So this is the grade. The arteries can be either encased or engulfed, and that depends on the arachnoid plane. So we can see that there are various grades of encasement depending on the amount of surface involved. So this is the grade. The arteries can be either encased or engulfed, and that depends on the arachnoid plane. So we can see that there are various grades of encasement. Involved. It is breaking.
I don't know what that audio is. We really can't hear it.
There is a lag between my presentation and the audio.
Yeah, I can't really hear the audio. Can you just comment rather than playing the audio so we understand what there's being said?
The screen is not on.
Okay, that's all right. You'll get it.
It looks like he has two devices working at the same time.
Just picking the wrong screen to share. There you go.
Yeah, fine.
There you go. Perfect.
Yeah. So the arteries can be encased and engulfed, as I have told you. So depending on the wall involved, we grade it as 1, 2, 3, 4, and 5. The grade 1 being only a part of the vessel involvement, and the grade 5, the major encasement of the vessels. The arteries can be encased and engulfed, as I have told you. So depending on the wall involved, we grade it as 1, 2, 3, 4, and 5. So when we are resecting a skull-base meningioma, we should be looking at these factors. The favorable factors are.
Excuse me, Dr. Kumar, you have something playing in the background. You have another screen playing. Turn off all the programs other than the one you're on. You have something else playing in the background. You have another screen open that's playing something.
You are right, Dr. John.
I think that's the problem. We'll get it. It's kind of a tricky platform sometimes.
Yeah, there's something playing.
Yeah.
How should I do that?
Just screen share and turn and don't turn the audio on for the videos.
Okay, can I switch off? I don't.
No, you're not screen sharing at all. There you go. There you go.
Yeah.
Oh, there you go. Perfect.
Screen sharing is not seen?
No, it's good. It's good.
Right. So I'll proceed now.
It's okay.
Yeah. So the favorable factors of a meningioma, is that if it is T2 hyperintense, it will be soft and suckable. So that makes the tumor surgery easy. Yeah. So, yeah. The absence of perilesional edema. The unfavorable factors are, if the tumor is hypo on T2, that means we are going to deal with a very hard or fibrous meningioma. If you are seeing a perilesional edema or a midline shift, that means that arachnoid planes are damaged and we are going to have a tough time. The long segment encasement means that the perforating arteries are involved and they will cause problems. Focal arterial stenosis again shows that the adventitia is involved and that makes the dissection very difficult. So the anatomical locations. The anatomical locations where the vessels are going to be involved or encased in a skull-base meningioma, the most common location is the medial sphenoid wing, followed by cavernous sinus and dipetroclival region. So these locations, we are going to be extremely careful because these are the areas meninges are going to incur. Example of this is a huge meningioma in the medial sphenoid wing region, where we see that the internal carotid artery is within the lid tumor and the middle cerebral arteries are outside the tumor like this. And we see that this is going to be a fibrous meningioma because it's a T2 hypo. So this becomes a grade 1 or 2 meningioma. And this is the video. As you see that this tumor, see the vessels, that is the middle cerebral artery, and we go towards that region. The fairly a good arachnoid plane is there, and this tumor is going to be coming out quite easily and comfortably. Why there is a lag between my presentation on audio and the PPT? It is not in time. There is a time delay.
Yes, sir. There is some time delay. So can we test it once? Just we want to see you once, so that we will see while we are seeing you. What's this thing? I think we have to test it once.
Yeah.
Thanks, Rakesh. Was doing other things.
Yeah. Sir, can we see you? Can you please stop the screen share and come on the screen?
Yeah.
Just click on the arrow again. That's it. Click on the arrow
when you started the presentation, when we could see you, it was all right. The audio was all right. Just for some time it has started this. There is some lag in the sound.
Okay.
Yes, sir. Can you speak now? Have you closed everything in the background?
Yeah. Yeah. Close all your programs besides this one.
Yeah.
I think you have another screen open.
The PowerPoint is open. That's all. Should I stop that?
Okay, that's fine. You can share the PowerPoint. That's fine.
Yeah.
Yeah, we are now. Now I feel your audio is reaching in time, sir. There is no delay.
1 minute.
Okay. It takes a while to get used to the tech.
Is it okay? Is it okay now?
Yeah, we can hear you properly, sir. Now.
Yeah, you can start your screen share. You can continue your
Yeah. Now
PowerPoint.
I'll do that again.
Okay.
Yes.
Now is it seen?
Yes.
Yes.
Yeah. Fine.
Yes. Perfect.
Yeah. So now that so we have seen that this video and post-op. So this meningioma is going to be a simple meningioma because we see that it's a good arachnoid plane and it's going to come out quite comfortably and we are going to have a good outcome. So the arachnoid plane is the most important thing in a meningioma will coming out. Now we're coming to the meningioma like this. If you see that, see this meningioma is hypo, that means it's going to be a tough meningioma. It's a fibrous or a hard meningioma. You are seeing perilesional edema here. That means that the arachnoid plane is breached and you'll have some tough time here. And you can see that the internal carotid artery is within the tumor and this case is going to be really a tough one. So you can see that the internal carotid artery is within the tumor and we are seeing the middle cerebral artery here. So the entire stretch of middle cerebral artery and the internal carotid artery is going to be within the tumor. So let us see this video as how, and if you grade 3, this is you can see that the 270 degrees in one area and almost in this region it is going to be 360 degree encasement. So let us see how this tumor is going to come out in a video. So you can see that. So you can see that this is so this is a tough meningioma. You can see that it is fibrous. So you have to use QSA and step by step gradually you remove this tumor. You see that is the middle cerebral artery, the Sylvian fissure. So always I follow the normal vessels to the tumor. That is the internal carotid artery. You can see that is the carotid optic space. So you go compartment by compartment. So you remove the tumor now in the carotid optic space. Use sharp dissection near the vessels, and this is the internal carotid artery, this is the anterior cerebral, this is the middle cerebral bifurcation. Use that's the posterior communicating artery. You're seeing that. So you have to be very, very careful. So the perforator damage also can be equally damaging. So once you are dissected the PCOM, then you can, the rest of the tumor we can comfortably remove without any problem. So that's how the tumor, if it is a rough meningioma, use a sharp dissection whenever possible. And this is the post-op MRI. You can see that the complete removal of tumor. You have seen that a small tumor is there along the vessels, but that is quite okay. We can follow these patients, and this is the patient. You can see that the good outcome despite the large size in the encasement. Coming to the tumor like this, you see that again hyperintense. You see that the previous case was hypo. That means this is hyper. It's going to be relatively a soft tumor. You can see again the internal carotid artery, the anterior cerebral, the middle cerebral, all are within the tumor. You can see that the complete encirclement, 360 degree encasement of these tumor vessels. You can see that the brilliantly enhancing tumor here. You can see that the vessels are all in this tumor. Again, you see that the vessels are in the tumor. And so this case, you have to have a complete encasement you are expecting. And this is a 360 degree encasement of the vessels. Now let us see the video, how it works. So in contrast to the previous case, which was quite hard, you can see that this is a soft tumor. You can see the good arachnoid plane there. So that is the middle cerebral artery. You are going towards the internal carotid artery, and that's the oculomotor nerve, third nerve here. So you are going behind the third nerve. You can touch the midbrain. You can see that the basilar branches. This is the posterior communicating artery, anterior choroidal arteries. So we have to be very, very careful in these perforators. So I'm going to switch to the compartment. Optic space, dealing with these perforators, and you can see when I'm trying to pull, the perforators are getting taut. So then I am pushing the tumor again to this compartment. You can see posterior communicating, anterior choroidal. So you are dissecting all the tumor there gradually, step by step. You have to be ultimately patient. The third nerve is here. So you can see that now the tumor is being separated, and that's the basilar artery behind. Basilar artery is seen quite comfortably. You can see that. So the whole tumor is removed. There's the optic nerve, opposite optic nerve. So soft is not that you concentrate only on the major vessels. The anterior choroidal are unforgiving. So perforators of the ICA has to be very, very carefully, meticulously dissected. That is the patient post-op MRI. You can see that there's a complete tumor removal. You can see the vessels are back to normal. There is a small residue in the cavernous sinus, which probably was vessels are within the tumor. The clinoidal meningioma, the medial sphenoid wing, are expecting a complete encasement of internal carotid artery, anterior cerebral, and middle cerebral artery. And you can see that there's a lot of mass effect here, midline shift, and there are some areas which are hyperinted, loss of arachnoid plane here, so you have to be careful. So you can see that the tumor is going down till the pons, and it's a globoid, ovoid shape, and it is centered in the medial sphenoid wing. So this is again a 360-degree tumor invasion and heart tumor. Let us see the video how it works. So you can see that. So that is the tumor here. So this is Sylvian fissure. The tumor is firm. That is the middle cerebral artery. You can see that there's an arachnoid there. So you gradually separate the tumor and the arachnoid here. Very, very patiently, carefully, you follow the middle cerebral artery towards the internal cerebral artery, internal carotid artery. Sorry. I can see that it could be comfortably dissected. Then this is the anterior cerebral. So the internal carotid artery is here. This I use quite comfortably, jet irrigation of saline that opens up the arachnoid plane. You can see the sharp dissection is being carried out. So in areas where there is no arachnoid plane, you have to use sharp dissection. Blunt dissection may injure the vessel. You can see that the whole anterior cerebral artery is now dissected, free of tumor, and then you go into further deep because it is going down to the pons. So you remove the tumor. That's a basilar artery there that you have seen. So you are removing the tumor piece by piece, sharp dissection, and that's the end of the tumor cavity. You can see that the whole vessel is free. So the strategies for a hard meningioma are different from strategies for a soft meningioma. This is another example of a similar case that you see previously. Again, a huge meningioma. There is, in contrast, you can see that there is a significant edema. That means that the arachnoid planes are lost. So you can see that the complete loss of vision on the optic nerve. And you can see that there's a lot of perilesional edema. That means that the arachnoid planes are already not intact and they have spiral breach. So this is again a huge meningioma. Let us see how this tumor works. And again, so normal to abnormal. So you are going through, that is the middle cerebral artery. You trace it to the internal carotid artery. That's always I do. That is the internal carotid artery. And we can already, anterior clinoidectomy is done. That is the dural membrane, a tumor cuff. So you open the tumor like a book, textbook, like how you open. You lay it open completely. You can see that the complete encirclement of cells. So the tumor which is behind the internal carotid artery, we should be very, very careful because that is the area where you have to be very careful. You always pass a dissector and see whether there's a space. So that's what is being done. You remove this tumor piece by piece. You can see that's a PCOM artery. That's a PCOM. So you dissect the PCOM and then you are safe. Then you completely remove it. You pass a dissector and make sure that the tumor is not adherent. Then you pull out the tumor which is posterior to the internal carotid artery because that is the area where if it is injured, it's very difficult to control it. That you can see that the end of the tumor, you can see that the complete excision. So here, majority of the time, a short dissection was used because the arachnoid planes were not very much intact. This is the post-op. You can see that the good improvement of the optic nerve. The tumor is completely removed, and that is the bone work. You can see that the anterior clinoidectomy was done. A lot of fat is kept to prevent CSF rhinorrhea, and the tumor is completely removed. You can see that it was a huge tumor, and the optic nerve is also decompressed. You can see, in contrast to the pre-op, a good improvement of the vision in the optic nerve post-op. And this is an interesting case of an old 65-year-old male. You can see this is a calcified, firm tuberculum cellular meningioma. You can see that the hyperosis of the tuberculum cellae and the planum sphenoidal, you can see that the big thick bone there and then the big tumor. What is interesting is that here it looks like the vessels are all separate. The vessels are all posterior. But I'll show you what happens intraoperatively. You can see that that is the anterior communicating artery, both distal anterior cerebral arteries. So this is the area of interest. So I'll show you what happening here. You can see how much attached it is in contrast to the MRI. These details were not available in the MRI. This is the anterior cerebral artery communicating complex. You can see it's quite adherent. So very, very fibrous, very hard tumor. So you need to be extremely patient, careful, and you are removing this tumor. You can see that the arachnoid planes has to be maintained. You can see that this stretch of vessels are completely adherent. The adventitia looks adherent. So I'm cautioning here. So sharp dissection, trying to separate the vessels from the tumor. You can see that extremely important. You use sharp dissection in such areas, never use blunt, never pull the tumor, you will injure the vessels. So you can see that once the sharp dissection is done, the tumor, that's the optic nerve. You can see that the optic nerve is also completely involved. So I cut the tumor just parallel to the vessels. That is the anterior cerebral artery distal. So you can see that I'm using a level blade because it is so hard. So you can see again, I'm trying to lift the tumor, but the vessels are also coming. So I decide to leave a cuff of tumor attached to the anterior communicating artery and the anterior cerebral arteries. You can see that now this small cuff of tumor is left, and then that is the opposite anterior cerebral. Now I have removed the tumor, leaving a small cuff of tumor. So whenever the arteries are very much encased or adherent, we can comfortably leave this tumor, and you can see that the post-op MRI, you can see a small cuff of tumor which is not even seen because you've already devascularized it, and complete removal, and patient is quite good. So this is an example of another 60-year-old male with a petroclival meningioma. So compared to the anterior clinoidal or a medial sphenoidal meningioma, which is quite shallow, that means once you do anterior clinoidotomy, you are on the tumor, but here the depth matters. In petroclival meningioma, you can see that the basilar artery usually gets encased, and that is the most distal part. And it is going to be very, very difficult because you are going to encounter it last. So I will show you how it is, and you can see that not only the basilar artery, you can see that the branches of the superior cerebral artery is also encased. I will show you the video how it is, and you can see that. So that is the superior cerebral artery. You can see that the tumor, how it is being dissected out. So you can see a good plane is there. So maintain that plane. You do sharp dissection, separate the tumor from the superior cerebral artery, and then you keep pushing the tumor. That's the midbrain. And you can see that the basilar artery, the superior cerebral artery. So that is a sharp dissection, and the tumor is completely removed. And that is the post-op MRI. You can see that. So the vessels are intact. So in petroclival meningiomas, you should be extremely careful. And the basilar artery is the last to encounter. And you trace the superior cerebral artery, and then you trace it to the basilar artery. And that's how you see and you identify and preserve the vessel. That's a patient post-op. It's complete removal of tumor done. And this is an interesting case of a 35-year-old female. She came with mild visual dysfunction. As you see in the MRI, the optic nerve is compressed by this tumor, and that's how she came to the hospital. She had partial visual loss, and it looks like internal carotid arteries are not attached or not encased. And that is when I'll show you some surprise here. What happens? So that is the anterior clinoidal meningioma, and that is the intraopic video. You can see that. So again, open the cilium fissure, identify the middle cerebral, trace it to the internal carotid artery. That is the anterior cerebral. So this is a hard meningioma. It's not a very soft meningioma. I am doing a sharp dissection, cutting the tumor. So going towards the internal carotid artery. Yeah. So reaching the internal carotid artery, that is the anterior cerebral artery. Middle cerebral, anterior cerebral, internal carotid artery. See what is happening there. See what is happening. When I'm trying to dissect it, sudden surprise. So there is an aneurysm actually. This aneurysm was covered by the meningioma. So when you try to remove the meningioma, this aneurysm slowly gets into picture. So we should be now extremely careful. So we can, aneurysm, if it ruptures, then it becomes a problem. So you can see that sharp dissection, I'm trying to expose the aneurysm. So using a sharp dissection, I'm not doing a blunt dissection there because aneurysm may rupture. That is the aneurysm there. And see, that's the PCOM. So basically it's a PCOM aneurysm. And once the aneurysm, then the rest of the tumor is now removed, and it is comfortably removed during sharp dissection. Sometimes these surprises await you. So when suddenly you will see that is the, you can see that the aneurysm is completely covered by the meningioma, and once that's the anterior, that's it. So I tried to clip it. It was like a blister aneurysm. So the clip was slipping. So I thought it's not a suitable case for clipping. So you can see that. So it is not suitable. So I just put some glue and then put some muscle, and probably the meningioma constant invasion or encasement has weakened the wall and predisposed to the aneurysm. So you can see that I put a small muscle patch there, just start of wrapping it instead of clipping it there. And so that is the end of this thing. So sometimes you see some surprises. Actually, I'll show you. This aneurysm was seen in the MRI. It was not identified or not just casually taken. You can see that probably this is the aneurysm. So this is a hidden tiger there in the aneurysm. So unexplained bleeding in a meningioma, in a skull-based meningioma with vascular encasement, always suspect that there may be areas of an aneurysm. I'll show you one case subsequently what happened. So this is a case, again, medial sphenoid wing meningioma. See that calcifications. So that is going to increase your job. It's going to make your job more tougher. The internal carotid artery, the middle cerebral artery is all being encased by the tumor. That is the angiogram. You can see that a significant proportion of the tumor is encasing the vessels, the internal carotid, the bifurcation, and the proximal M1 till the bifurcation. I can see that a significant portion and it is calcified. So let me show you the video of this. You can see. So that is the middle cerebral artery. You can see that the arachnoid is maintained there. So terminal approach. So you can see that the arachnoid is, there's a good plane of arachnoid there. So you cut the arachnoid, you dissect it, sharp dissection because it's quite adherent. So always sharp dissection in such areas helps you to prevent, and never dissect the tumor with a big bulk of tumor. So always reduce the tumor to a small size before dissecting on the vessels. We can see that that portion is difficult. So I use the saline to cause jet irrigation, and that helps opens up the arachnoid space. Then you proceed for cutting the arachnoid there. Use sharp dissection again. So again, debulk the tumor, then work on the vessels. So that is the principle. You always reduce the tumor to a small chunk. Sharp dissection. Go parallel. Cut the tumor parallel to the vessels. You can see that that is being done. You know to some extent that how the vessel courses. So you leave a cuff of tumor. You can always come back and remove it. And you can see that how the vessels are being dissected and the sharp dissection. So sharp dissection in these areas are very, very helpful. Whenever you do blunt dissection, you may injure the vessel, however small the vessel may be. So you see that the vessels, you have to play around the vessels. You push the tumor on whichever side it comes out and you remove it and you debulk the tumor. So parallelly, you debulk the tumor, cut the tumor, and then dissect the vessel. So this should be in cycles to avoid a vascular injury. You can see that once you have dissected it, now you can cut it and reduce the tumor size before proceeding to the next segment of the vessel. And you can see gradually, step by step, you should have utmost patience in dissecting these vessels because the outcome of these meningiomas directly is proportional to the vascular damage. You can remove the tumor out. If you produce a vascular damage, then the outcome is not going to be great in skull-based meningiomas. So you can see that the vessels again. So you trace the vessels. You can see that the complete extent of the vessel is now dissected off the meningioma. Go patiently. You can see now the vessel is completely free. Now the vessel is completely free, and now you flick around and you remove the meningioma. See that? So that's how. So you use a combination of a sharp dissection and a blunt dissection, and you can see that the vessel is completely separated. And once you have done that, now you go to the again base and you cut the tumor. So this cycles has to be repeated serially, step by step. You can see that now we're going to the main check. You go to the ICA. In a short time, you see that that is the internal carotid artery. So that is the internal carotid artery. That's the middle cerebral, anterior cerebral artery, which we have dissected out. And you go towards PCOM. So whenever you go to the ICA, you dissect out the PCOM and anterior carotid artery first. Then you know where they are. Then you can proceed with the rest of the tumor. You can see sharp dissection, the perforators. So you use a blunt dissection if possible. If not, you use sharp dissection. So again, gradually, that is the PCOM artery there. You can see that the PCOM is coming in way. So you separate the PCOM and then you lift the tumor off the ICA. That's it. You're done. And once you identify the PCOM and anterior carotid, then the rest of the below the tumor, you can remove it comfortably. You can see that how it is coming well. Yeah. So the anterior carotid, what you saw, and now the PCOM. So this is the anterior carotid artery. the PCOM artery here. So you open up gradually, go step by step. You see that? Yeah. So again, come back. Now you have dissected the vessel, you know where it is, you debug the tumor. So this cycles, you can see that. So this is the rest magnified area. So you come back again, and I'll take you to the next part of the video now. So that's it. The second part of the video. So once you dissected, you go towards the internal carotid artery, you remove till go to the proximal dural ring. Again, this is near the proximal dural ring. So you are done the anterior craniotomy already. So you are cutting out the tumor, separating the tumor here. So on either side of the internal carotid artery, you go and then remove the tumor. You can see that these are quite difficult steps, but it is possible. So you can see that a small cuff of tumor here and there left, the adventitia is not free. So you can leave behind a small cuff of tumor if it is adherent, that's a posterior communicating anterior choroidal. You can see that the complete tumor is removed, and that's the end of the surgery. So a small cuff of tumor, if it is adherent to the internal carotid artery, can be safely left behind because you already devascularized, it is unlikely to grow. So that is a post-op MRI. You can see that the tumor is completely removed, the vessels are all intact. Arterial injuries. So what do you do if there is an arterial injury in case of during surgery? So this is a delayed complication. As you see, this is a case of petroclival meningioma, and this patient was doing well. On 8th post-op day, when he was planning for a discharge the next day, suddenly he lost consciousness and he became GCS4. He was decelerating the ward. Then we did it, took him for a CT scan. You see that the massive subarachnoid hemorrhage everywhere, and then same sitting, we did a CT angiogram, and then the DAC, we can see that there was a small aneurysm, a blister-like aneurysm in the basilar artery, and this patient, probably this was not noticed during the surgery, it was anterior, and it was missed after maybe the meningioma was protecting the aneurysm, and once the meningioma was removed, the aneurysm had opened up because of the vessel weakening. Immediately a stent was deployed, but it was in vain because we lost the patient subsequent day. This is a young boy. I operated some 8 years back. I thought it was a trigeminal schwannoma, but it was a meningioma. It's a huge cavernous sinus meningioma, multi-compartmental, going into the posterior fossa. And this patient, the tumor came out quite well, but towards the end, when I was removing this portion of the tumor, it was late in the night, early morning probably, because it was taking a lot of time, and there was a rent in the internal carotid artery. I tried to suture it after clipping it, but the vessel was already so narrow and thinned out, and the vessel wall was so fragile, and I couldn't repair the vessel. I just had to pack it and come out. And this patient, luckily, had a good cross flow, and this is a post-op MRI, and he came out quite well without any deficit because of the good cross circulation. This is a meningioma, again, a large minoid-sphenoid meningioma. The internal middle cerebral artery was completely encased. And when I was dissecting it, I don't have this video. When I was dissecting it, there was an injury in the M1 and had a tremendous blood loss. And then what I did do, I immediately asked our CTVS cardiothoracic surgeon to take a venous graft. I was operating the tumor, I was controlling it, and he took a venous patch and then gave me. So I did an end-to-end anastomosis. I could identify the both sides of the M1. I did an anastomosis end-to-end, and I could preserve the vessel continuity, but then the perforators were lost. And so, though the patient did not have a large MCA infarct, there was a small lacunar infarct in the internal capsular ganglia capsular region. I didn't close the bone flap. I left the bone flap and then came back and did the cranioplasty later because I was anticipating a brain bulge. But luckily, because the anastomosis worked, the bypass worked, and then she didn't have a hemispheric infarct, though ganglia capsular infarct, you can see that. So that's some white spots. The main vessel can be preserved, but the perforators were lost. And this is at 3 months, she was able to walk, though she had weakness, a hemiparesis of grade 3 to 4/5. So that is not a really good outcome. I could have been a little bit careful, but sometimes it happens. So to conclude, what I do is there are a lot of studies where they do an anterior craniotomy and they identify the ICA just medial to the anterior clinoid and then proceed to the tumor. But I was not comfortable. I always do the reverse way. I do a large stereonal craniotomy and then I open the cilium fissure widely. I follow the normal vessel to the tumor. And I debulk the tumor internally completely before dissection of vessels, because dissecting the vessels with a huge tumor will cause problems. And always leave behind a cuff of tumor around the vessels and perforate as if it is not coming out. You can use combination of a blunt dissection and soft dissection, sharp dissection. If there's a good plain arachnoid and soft tumors, you can do blunt dissection. But if it is a firm tumor and if the adhesion, the arachnoid is not very good, you always do sharp dissection, because if you try to pull the tumor, the vessel may get avulsed and you'll get into problems. In large ICA, I don't have a neck, but probably people who begin to do that can have an ICA neck control. In case of an unadvantage injury, you can always clip it and try to suture it. That's one advantage. You can reduce the flow, you'll try to identify the rent and then suture it. Whenever possible, microvascular repair of a vessel should be done, as in one case, or a bypass, immediate emergency bypass. If you suspect that you have injured vessel and then you have repaired it, or you have put a muscle patch and you have coagulated it, always do an angiogram, because pseudoaneurysms can occur on the follow-up. So thank you for your attention, and this is my contact details, and you can contact me or mail me if there is any doubt or anything.
Very good. Thank you, Dr. Kumar. Excellent presentation. And I think I'll let Ipe moderate. Go ahead, Ipe, take over.
Can you hear me?
Yes, we can.
Yes, Dr. Ipe. Good evening.
Hi, Rupesh. So good to see you again, man. Rupesh and me go a long way back. I remember I was one of his guest faculty in 2014 National Skull Base meeting 4 years back when he held his National Skull Base meeting in South India. So I still have the memento that he gave me in my office right now. So Rupesh, excellent presentation as usual.
Thank you, Dr. Ipe. Thank you.
Very good talk. Very good talk. Proud of you. And very honest and very sincere and very skillful videos, as I can see. I mean, way to go. One of the things I would suggest, I would commend is, as you said, always we have to reduce the tumor and then only go around. And one of the things I do is when I leave the tumor, I take a tumor holding forceps, and under the microscope, I have a lot of patients. I keep on milking the tumor around the vessel which I have left. So I take a tumor holding without the teeth. Then I keep pressing it. So milking out the tumor. So this way, what happens is only the arachnoid is finally left and all the tumor particles come out. So this has worked for me. This I have seen Dr. Pranatharthi Haran doing it.
It's a soft tumor, it works. Soft tumor, it works, but in hard tumor, that milking technique usually doesn't work well. So you need to do, soft tumors, it really works like that.
I agree. Hard tumors, sometimes it's difficult to milk it out. So, excellent. It's okay. It's otherwise excellent. And arterial injuries also excellent. I mean, we've had many of them. I mean, we've tried anastomosis, but whenever there's nothing planned, it's always a problem.
Yeah. So that case actually, I could identify the rent. I could identify, so I trimmed it, and then I could identify the cut edges of the vessel and a small patch of the venous. Immediately I could get it, because I was in the tumor. I asked luckily the next door, the CTVS technician was there. He immediately harvested a small venous patch, and then we could do an end-to-end anastomosis and kept on irrigating, flushing with heparinase saline. So that is very, very important. Whenever we injure a vessel, we need to distally, the vessels should go for thrombosis. So we need to keep on irrigating with heparinase saline, so that technique really helps, so that it doesn't get thrombosed, because it is not a planned bypass. So I just kept it on, asked the assistant to keep irrigating with heparinase saline. That's how I could salvage it.
I agree. I completely agree. Also, as you said, we always get neck control if there is we anticipate a problem. We always get neck control. Thank you very much. Once again, I ask Ahmed to take over.
Dr. John, you're mute. Dr. John, you're mute.
Okay, I'm sorry. Thank you. First, we're going to ask some questions, Ahmed, before we start with you.
Hello, everyone.
Yeah, hold on, Ahmed. Let's finish up this conference first. Raphael, Margarita, Juma, or Duong, Amer, do you have any comments on Dr. Kamira's presentation?
Yeah.
Go ahead, Raphael.
Okay. Hello, Dr. Kumar. Thank you so much for your presentation and nice cases. I enjoy a lot seeing the cases that you present. And I would like to ask you some technical advice, probably coming from you, and also sharing some experience as well. One thing, I saw one case. I think I was it was a tuberculum cella meningioma, which I'm not sure, but I think you approached by a terminal approach. And I would like to ask you, because many people says that they prefer to choose a terminal in case there is some kind of visual impairment, in case you can liberate the optic nerve. And the second case, I was so impressed by the case you present. I think it was clinoidal meningioma, that you have an aneurysm that seems to be a blister-like aneurysm. I was so impressed by that. I mean, I was so impressed. It was also a little bit of luck, but that was a really nice case. Congratulations for that case.
Thank you.
And the other case was an sphenopetroclival meningioma. I think is more petroclival. And you approach, I think, by a retrosigmoid or parasigmoid approach. I'm not sure about which one you choose. And
it's a retrosigmoid.
It's a retrosigmoid. That's amazing as well, because you have a bunch of the tumor right in from the pons that was also displacing the basilar artery, and at the same time was going through the cavernous sinus, which is very impressive for me. With the experience of Dr. Mura, we have been choosing in the last couple months, I mean, the last several years, we have been choosing a middle frost approach, which you do extradural, anterior clinoidectomy plus liberation cutting the 10. It gives you a nice exposure. While when we are comparing choosing posterior fossa approach and middle fossa, we have seen that when we choose a middle fossa approach, we don't see as many facial nerve impairment after post-op or auditory nerve impairment. On the other hand, when you choose a posterior approach, you have more facial nerve and eight nerve impairment. But you concern more when the extraocular muscular nerves are conserved. So I don't know what's your opinion regarding these terms. And also the fourth question is, I didn't see really, but I think that you are a skull-based and vascular neurosurgeon. I would like to ask you, what are your thinking and your opinion regarding the extradural versus intradural anterior clinoidectomy for this type of cases? Thank you so much.
So it's a good valid thing. So whenever I go for a tumor, a clinoidal meningioma, skull-based meningioma, I would prefer an extradural approach, extradural clinoidectomy. That becomes very simple, and it's a relatively simple and it's easy to do extradural than intradural. But if it is a vascular, like in paraclinoid aneurysm, I would always prefer intradural and intradural clinoidectomy. Never I'll go for an extradural. And coming to the other point, the middle fossa versus a posterior fossa approach for a petroclival meningioma. So it's always a debatable, and whichever you are comfortable at, you can do. It's both are okay. As you told correctly, if you go for middle fossa, you get more of an extraocular nerve paresis in the immediate post-op, and if you go retrosigmoid, you can transient facial nerve paresis. But usually they recover. They don't. It's not a permanent injury, but what here is that retrosigmoid, it is a supracerebellar, lateral supracerebellar. You do a retrosigmoid craniotomy and then you go supracerebellar, and you have a very good wide approach, and you're shortest to the tumor compared to what you do from a middle fossa approach. Maybe it's how you are comfortable with the technique, but I would prefer a retrosigmoid for a petroclival meningioma if it is predominantly in real petroclival. Because if you come from middle fossa, if the tumor is coming down below the internal auditory meatus, that is the area where you cannot reach the tumor and you want to go definitely. Or you can always combine it. The one case which I showed is a soft tumor, sphenopetroclival meningioma. I did initially that's anterior clinotomy and then removed the supratentorial part. And stage 2, I removed the tumor from the retrosigmoid approach. So it's a combined two. I didn't show the video of a second approach for the want of time, but then in such tumors we can always stage it and then do 2 different approaches. But whichever approach we use, I feel the safety, the least morbid procedure should be adopted for that particular patient.
Thank you so much. Really impressed. Thank you so much for your presentation, and go ahead and keep on doing what you're doing already.
Okay, thank you. Duong, you have a question you want to ask Dr. Kumar? Duong, you have to unmute. Yeah, there you go. Go ahead.
I have a question. Do you make the LP before the operation for relaxing the brain or not? Thank you.
Sorry, I didn't get the question. Sorry?
One more time.
Do you perform the number LP for relaxing the brain for operation or not?
Yeah, we're getting a lot of background noise there.
Yeah.
Can you text the question, please?
I got his question. I just want.
Okay, go ahead. Go ahead, Vikash.
Sir, he is asking if you do a lumbar puncture regularly so that it relaxes the brain. That's what he's asking.
Okay. No. It's not safe to do a lumbar puncture because you see that in a lot of the time there you can cone. The patient can cone without your knowledge, and it's always better to open the cisterns because whenever you go, you open the cistern, you try to release the CSF. And lumbar puncture is not really. I don't think I have used lumbar puncture for any of these patients because you can once you open the ciliary fissure, you're going to let out the CSF under control, under vision, and that may not. Some people may do, but that's not a good idea in my opinion.
Okay, very good.
Thank you.
Margarita, you have a question or comment?
Yeah.
Go ahead. Go ahead, Margarita.
First of all, congratulations. It was an amazing
You're muted, Margarita. I don't know why we're not hearing you. Okay, hold on. Let me test here. Maybe it's me. Okay, go ahead, Margarita.
Okay.
Go ahead.
First
Go ahead,
of
yes.
all, thank you very much, Professor. It's an amazing presentation. My doubt is about if you use for paracellular meningiomas endoscopic approach combined with microscopic approach. Do you have an experience? And please, if you have some case, can you show us a little bit?
The combined endoscopic and microscopic. Yeah.
Yeah.
So
combined for paracellular that you show us.
If you have time, can I show a video of that?
Yes.
Tuberculum cellular meningioma?
Sure, if you want to.
Yeah, fine. So I'll just take you to a video. So this is a tuberculum cellular meningioma. Yeah, just a minute. So this is the tuberculum cellular meningioma transnasal endoscopic approach. You can see. So that is the tuberculum cella. You're drilling the tuberculum cella. That is the cella. So that is a planum sphenoidal here. So you keep drilling it. That's a planum being drilled. And so you see that there's some intercavernous region, anterior intercavernous, and there's some blood there. You proceed. So you can see sometimes it may be a torrential bleeding sometimes, especially from the anterior intercavernous sinus. So you can use a Surgiflow or Flowsil adjunct, but you keep a sucker there, and then you proceed. You drill. You keep drilling the tuberculum cella, step by step. And you can see that thinning out. Usually these meningiomas, the bones will be thick. So you need to spend a lot of time in drilling these bones. And so you can see that that is the region of the tuberculum cella. Dura is seen. So you combination of drilling the rongers, you remove the bone. The most important is the approach here. If you have navigation, that is very useful. That will be very helpful to know the extent of the bone removal. So here I am trying to control the bleeding, which I had. with the bipolar, but usually it doesn't work. So you can see how I manage. I just wanted to share this also. And this bipolar usually doesn't work for anterior intracavernous sinus, because you use the bipolar, it will open up. That's what happened. So you can see that bleeding sometimes is troublesome. So you can see how the bleeding is. And I am using so many adjuncts here. I put a gel foam and see it's opening him up again. And I use Surgicel. Nothing works. I'll show you how this bleeding was controlled. You can see torrential. There's an intracavernous sinus sometimes can be very, very troublesome if you're drilling. And you can see that that's a Surgiflow. So the moment you use Surgiflow, you can see that it's beautiful. It's just a magic. That bleeding stops. Usually, without these things, I don't usually go in, because this is a very, very valuable adjunct. The bleeding stops immediately and we can proceed further. So that bleeding is stopped now, then we are proceeding with the bone removal, and that's a tumor. You can see that. So that's a tumor, tuberculum sella, the meningioma, and gradually keep removing the tumor. That's the, so once you get to the edge of the tumor, then you can start dissecting. So here what they do is the ENT surgeon holds the scope, and I use two hands. I use a left hand section, the right hand the dissector. So the same microscopic principle is being used. You can see that slowly the tumor is being dissected out. I gradually dissect the tumor out. I see that. That's the optic chiasm, the white thing you're seeing behind. So gently you remove the tumor of the optic chiasm and you debulk the tumor then subsequently. So you can see that slowly you keep pulling the tumor gradually. Pulling in the sense that very, very gradual pulling. It's not that you should not avulse any vessel behind. So you keep dissecting and see what is behind, and then you remove the tumor in piecemeal. So I just go around, remove the tumor. I just forward the video. Yeah, that's that. So you put a curette there and try to curette it out. It's a soft tumor. You are already devascularized. The moment you remove the dura, you remove the tuberculum sella bone, you are already devascularized the tumor. So you use a punch, pit by pit, you gradually debulk the tumor. The anterior cerebral, the glimpse of the anterior cerebral artery is seen there. You can see that the anterior communicating artery is here. So you remove the tumor, you can see piecemeal, remove the tumor from the optic nerve this side. So in a way, you see the anterior communicating artery completely. The coordination between the ENT surgeon and the neurosurgeon is very, very important, because we should have a good synchrony between us. I'll just go again, forward it. So you remove the tumor piece by piece. Yeah. So now the whole optic chiasm and the optic nerve is seen on this side. So that is the anterior communicating artery. So this moving of the scope in and out gives you a 3D appearance. So the major limitation of endoscope is that you don't have a 3D perception. So how do you convert this 2D into 3D is that you move the scope forward and backward, then you get the depth perception. So you are trying to now remove the tumor of the ipsilateral optic, that's left side optic nerve. So now you're seeing that the most of the tumor is removed except a small portion of the tumor in this optic groove, optic canal on this left side. We are seeing that the anterior communicating, the both anticerebrals are intact, the pituitary stalk here, the optic chiasm is seen completely here. So you try to separate the tumor of the optic nerve, it is quite adherent there. So you put the ball dissector is very, very helpful in these cases to dissect it from the arachnoid. So you gently remove the tumor, you keep dissecting out, so like a microscope, what you do, the same principle. You use two-hand technique, one hand section, the other hand your dissector. So you completely remove the tumor and as like a microscope. So I just forward it again. So when it is not coming, you can actually leave behind that, because you should not risk damage the optic nerve. So there's a last bit of tumor is coming out. So that is being removed. Gently, gradually, you dissect it out and you remove that. So care should be taken that whenever there's a traction of the optic nerve, you should stop it. Then you should see, release it, and then do sharp dissection. You can use scissors. You can see that. So having a tough time with that tumor there, but patients, gradual dissection, twisting, the tumor usually comes out, and you can see that now the sharp dissection is being used. They use a scissor to cut that last bit of tumor because it was causing some traction on the optic nerve. So there's a last bit of tumor being removed. So you see that. So you can see that the optic nerve, the optic chiasm, the anterior cerebellum, both sides, anterior communicating artery, the pituitary stalk. So all are in your vision. And the most important next thing is the reconstruction. So very, very important that you reconstruct to prevent CSF leak. So that's the end of the tumor cavity. So the arachnoid actually is intact there. Most of the places the arachnoid is intact. That is very, very important. So I usually do a 3-layer technique for closure. That is the free fascia lata. Inside, I use always an inside inlay fascia. That's the vascularized Hadad flap. I'm going to use that. So this is the, I usually keep this bone. This bone supports the inlay graft and acts as a buttress, a gasket technique. So that is a bone, a piece of bone which you remove from the cell. You keep it back, and that will support the fascia. And over this bone, I keep the vascularized flap, which I'll show you now. That is the Hadad flap. So this is the vascularized Hadad flap. I am reflecting it, and then I completely take it till the tubercle cella. So there's a 3-layer technique: the inside free fascia, the bone, then the vascularized flap, and then I support it with fat, and then you use some fibrin glue at the end. So that's it.
Okay, very good. Thank you very much for taking the time, everybody. And we're going to start with our next presentation. And you're welcome to present anytime you want, Rupesh, in our community. Every Sunday we have these get-togethers, and we're glad to have people like Raphael, Margarita, and Ahmed participating, as well as Slaven, a student. So, Slaven, you want to say hi real quick to everyone?
Yeah, hi everyone, and I'm really glad to be here. I'm sorry for the delay of my coming, but I'm really happy to be now here. Thank you.
Yeah, he's the future. He's the future's neurosurgeon from Croatia.
Thank you, Rupesh sir. It was an excellent presentation. Thank you so much.
Thank you.
It was very
excellent. Thank you. Thank you.
Okay, you're welcome to stay if you want. Okay, I'd like to introduce the next speaker, Ahmed Al-Gradi, a Yemeni neurosurgeon resident, and he's in IPE's office right now. How you doing, Ahmed?
How are you?
Good. How you
doing?
How
are you? How are you doing?
You're in the Baratnagar. That's great. Okay, I'd like to introduce you first to the neurosurgeons on the panel. First, we'll start with Amir.
I'm Dr. Ahmed Al-Gradi.
No, hold on. Let's introduce the panelists first, okay? I want you to meet them, okay? Just so you know who's watching. Okay, Amir, could you please introduce yourself to Ahmed?
Yes. Hello, Mr. Ahmed.
Okay, I'm sorry. I got your audio turned off. Go ahead, Amir. Go ahead.
Good evening, Mr. Ahmed. My name is Amir Badran. Salam alaikum.
Alaikum assalam.
Alaikum assalam.
There we go. He's from Jordan.
Yes.
And he's practicing now in the Ukraine. I'm sorry, Margarita. I should have introduced you first. But could you say hello to Ahmed, please? You're muted, Margarita.
Yes, Professor. Morning. My name is Margarita. I'm from Brazil. And I'm a former neurosurgeon right now.
You're in Portugal now, right?
Yeah, Professor. I live and work in Portugal.
Okay, welcome, Margarita. Raphael, could you please introduce yourself? Go ahead, Raphael.
Hello, can you hear me now?
Yes, we can hear you.
Okay. Hello, doctor. This is Rafael Martinez Perez. I am a Spanish vascular and skull-based neurosurgeon. And thank you for sharing your experience. And I hope to enjoy.
Okay, very good. Welcome, Rafael from Chile. Okay, Rakesh.
Hello, everyone. I'm Dr. Rakesh AV, neurosurgery resident from India. Thank you for inviting me for this presentation.
Okay, welcome, and we met Slaven. Okay, Ahmed, it's all yours.
Hello, everyone. I'm Dr. Ahmed Al-Gradi, I'm a neurosurgery resident from Yemen. I'm in the Indian residency program, and I came here to Britnagar under the supervision of Dr. Aib Shirian for a fellowship program under the SNS community. In this period, I learned a lot and I have a lot of experience. I will share with you some of the works and some of the operations I see with Dr. Shirian and Dr. John and Dr. Yuga.
I was tutoring him from Bharatnagar.
Hello.
Hey, Ike.
Hey, John. We having a problem with screen sharing, man. So
Okay, well, take your time. Take your time. No hurry.
now what we can do is we can get. I mean, we can do this screen sharing in the other computer, but then we won't be. We have to talk from this link
Well, you know,
address.
you can email me the PowerPoint presentation if you want. And I can screen share.
No, that's a huge file, man. I mean, that's
okay.
going to be a huge file. So what we will do is we will just show you what's happening, and then I don't know the audio. We will have to go through this lead. So we will keep this window on, and then I will open the other window, and then I'll try to screen share. Okay, let me see
let's
this.
try. Let's try to improvise.
Okay. I'll use it on the.
So, yes, we had 8 neurosurgeons here at one time, Slaven. Just hang in there. We can get it going, I'm sure. Well, I'll take this chance to tell you about we're televising a couple of conferences from Italy, actually at the end of May. One from Puglia, which is a town, I believe, in the west part of Italy, the cerebral vascular. And the other one, okay, Ike, what are we doing here? I think. Okay, yeah, okay. I see your screen. Yeah, we see your screen. Just go ahead. There you go. I believe they're trying to screen share from one computer and the audio is from the other. Okay, yes, we see it. Can you hear me?
Yes,
yes, we can see you. I think we're getting a little interference. You may have to turn off the audio where you're screen sharing from. That may be the problem. You're getting a feedback. Okay. Can you describe that, what you're doing? We're not getting audio there, right? Try the audio from one of the computers. If that doesn't work, we have to try it from the other. We see the screen share fine.
Okay. Can you hear us now?
Yes,
Now
we can hear you now.
We can hear you.
As you can see, this is a case operated this week, Dr. Akshirian, a case of a huge CB angle tumor. Okay, this is scan. This is the marker and the incision was done in the lateral position. Here you can see the dural opening, and you can see that the brain was tense, no pulsating, and the clinician had to open the dura deep down to the upper cervical region to try and get the CSF out, as you see here.
That's a marginal sinus near the pharynx.
This is the marginal sinus at the crown magnum level. Okay, what's happened here?
We're seeing the screen sharing fine.
Okay. Now you can see the CSF coming out.
Yeah. Yes.
And the brain getting lax.
Yes. Seeing
You
it
can
fine.
see now. You can see the pulsation in the brain.
Yeah. Yes.
CSF coming out. You can see the pulsation in the brain, very nice, becoming very lax. And now we'll start the dural opening. This operation was done by a remote approach. You can see here the dural opening. Now I'll fast forward the video a little bit. You can see here the traction of the cerebellum and getting through the arachnoid plane to identify how to expose the tumor, which we will see right now. You can see the tumor starting to appearing. It was a huge tumor and was very vascular also. Can you see the tumor? This section gently. Here you will see that cauterization of the tumor and start to developing the tumor from the inside. At first, before any section around it. can see the bulking of the tumor from the inside. And as you see, it was a vascular tumor. So some bleeding in the tumor, large tumor like this is somewhat expected. But you don't need to worry. If you have a lot of bleeding, you can use a Bati and a saline, and it will eventually stop. It's all inside the tumor capsule.
They were behind the scenes as a live.
You can see how the tumor margin become more large when we proceed with the debulking of the tumor from the inside, and which help us to do more mobilization of the tumor. As I told you, some bleeding and large tumors can be expected, but you don't need to hurry or to lose control. You must be calm all the times. If the bleeding is getting too much, you can use normal saline and Bati to control it as much as you can. You can see this large vessel bleeding the tumor and was causing a lot of bleeding. Now, after debulking of the tumor, you see that we start do the section. This is one of the cranial nerves, cranial nerve number 8, cochlear nerve.
No, that is 9, 10,
9, 10, 11, sorry, 9, 10, 11 nerves. We protect them with a Bati and proceed with debulking. Here you can see that start mobilizing the anterior part of the tumor. Gently and slowly. Mobilize and continue debulking from the inside.
That's a tent.
This is the tentorium. Supracerebellar tentorium. To mobilize the tumor from the tent and control small lizards. Here you see that we're proceeding with the debulking of the tumor from the inside to give us more space and more freedom for mobilization of the tumor.
The tumor is not being moved. Here is user.
This is CUSA. It's very helpful in such cases. You notice that the tumor is only mobilized, not pulled or moved, to protect the cranial nerves and the surrounding structure as much as you can, and to prevent also to prevent avulsion of the attaching vessels. Now we can see that tumor is mobilized from the medial aspect and posterior aspect as it developed, which become more easier for mobilization. In this stage, you must not hurry and try to take it at once. You just do the section and identify the arachnoid plane and continue with debulking. And if you take only piece by piece, not to try to pull it as one piece, because you can cause injury to the cranial nerves or the visits. You see here how it's mobilized. Verticality and direct nose blade. And you continue with debulking of the tumor. And you can see. You see CSF starting coming out as we mobilize the tumor from the brainstem and the seromedial margin. And we use glucose now for further debulking before we pull out the tumor. You can see. You can see now that some of the tumor are coming out very easily with no much pulling, with no much force. So we take fragments of it. And as Dr. Chiren said, you treat it as the tumor as a woman. If she is willing to come, it will come to you. If you're not willing, you must not force it, because you might cause injury. Taking pieces of the tumor. You can see how it's come out easily with no much force, no much pulling. Some bleeding from the the tumor bed. This can be expected. We control it by putting batty and irrigation, continuous irrigation with normal saline, as you can see here. Yeah. Now you can see this is the tumor bed. These are the cranial nerves. You will see now. Yeah. If there is any small oozing, you can control with bipolar. This is the 8th nerve, cranial nerve 8. This is the facial nerve right here. You will see now.
It's a 5 centimeter tumor.
It's a huge tumor. You can see the facial nerve. It's preserved. This is the facial, and this is the 8th nerve.
It means posterior. 7 is anterior.
So this is the tumor. Now after irrigation with normal saline and battery, you can see how hemostasis was achieved. No much bleeding, oozing stopped.
Operation time is 2 hours.
Okay. The operation takes about 2 hours from the dural incision. And then closure. You can see here a picture of the patient.
Yeah, you can.
We'll show a picture of the patient the next day, second day after operation. He was doing well. Okay. You can see this is the patient. He's doing very well. Conscious. There is a grade 3 facial palsy that will improve with time. There's most aggressive images. There is only some bleeding and some surgery seal. And the patient is well and transferred now to the ward today. The second case is a coronary pharyngioma case. We can see from here. Okay, let's open the video.
You have to come here.
It's a case of coronary pharyngioma. After the video, I will show the preoperative CT scan. It is big coronary pharyngioma with cystic lesion. It's reached the third ventricle up until the lateral ventricles. This is a temporofrontal approach. This is extradural transcavernous. The orbitomeningeal band also already dissected here. And this is the orbital roof. This is frontal loop, and this is the temporal loop. You can see here the dissection of the dura from the true membrane of the cavernous sinus to allow separation from the temporal and frontal loop, which give us more space and more exposure to the tumor. You can see the section from the cavernous sinus. This is the anterior glenoid. You can see from the extradural space. Dealing with the dura from the cavernous sinus. Here in the stage, one should be very gentle to avoid injury to the cavernous sinus because the membrane is thin, so you don't need to do much force. This is with the AC Dr. and left normal. Now you can see the house separation between the temporal lobe and frontal lobe, wide separation and very nice wide angle. The ear is opened. Now you can see here that arachnoid space restricted to reach basilar region. You can see here the optic nerve is here. Here is the carotid artery. Slow dissection. This is the frontal lobe. This is the temporal. Here is the optic nerve. You can see here. And this is the cella, the optic chiasm. Sharp dissection of the arachnoid is done to widen the angle and to widen the space. You can see the chiasm. Here you can see distal separation of the arachnoid, the Sylvian fissure. It's opened, and you will see the carotid artery here, the carotid artery. And after opening of this arachnoid, you can see the tumor very easily in this area. This is under high magnification, very narrow space. You can see the tumor. You can start to see it. This is the internal carotid artery. It's a very narrow space, as you can see. This is under high magnification. The soft part of the tumor will be removed gently now, as you will see now. Slowly and gently. Here is the fourth nerve, fourth brain nerve. Now you can see the cystic part of the tumor. This is the basilar artery here. You can see in the back. The cystic part of the tumor will be opened. This is the part of the cystic. The main cyst will be opened now, and you can see the content as you see here. And it will shrink the cystic margin. This is the content of the peripheral tumor. Check and with irrigation of saline also help. Now you can see that it's mobilized slowly by using suction and the sector. Mobilize it very slowly and remove any adhesion between it and between the arteries. This ventral carotid. You can see now in a minute the anterior choroidal artery also has been dissected from the tumor. You can see that it's mobilized and dissected. Very slowly, with no hurry. See the tumor is coming out. See it's been mobilized very nicely. You can see the basilar artery in the back here. Tumor involved gently and slowly. If you find any resistance, you should also proceed with the dissection. You can see it's coming very nicely. This is the basilar artery. Here you can see the anterocardial artery in this area. Under the anterocardial artery, is dissected out from the tumor. This is anterocardial artery. Tumor is immobilized. And dissected gently from the surroundings. Now you can see how it's come out very easily and very nicely. Do it slowly, step by step, as it's come with no much resistance. Because of this oozing, as I told you, we can use irrigation of saline and it will stop eventually, as you will see now. It's very narrow window, and as you can see, the basilar artery is one in the back. For the irrigation, you can see that you can achieve a good hemostasis. No surgical was used. Patient now is in good condition, and it's planned to send her home tomorrow. Now I will show the pre-opened best of the pictures of the CT scan. Share.
You can open the PowerPoint. Yes,
Yes,
and there, it's open. This one.
Yes. Here's the pre-op image. No, before that. Before. Yes. This will be this post-operative images. You can see complete removal of the tumor. This is the pre-op. Like this one.
You can show us.
Okay. There is some problem. I can't open it now. Here there's some images from the operating theater. You can see here in the Betnagar, they have very advanced facilities, very good theater, very good staff. I have the opportunity to watch some of the best neurosurgeons doing a lot of surgeries, like Dr. Evcherian and Dr. Juha from Finland. And they have also a microscope and a lab for training. I can show you. This is a microscope we use for training of the anastomosis. This is some of my first anastomosis when I trained. And this is the last one. You can see how much improvement. Okay. They have 3D screen. You can observe with the 3D glasses. It's a very nice experience. And thank you.
Very good, Ahmed. Thank you very much
You.
for a great presentation. Okay, we have a few people still here. Amir and Rakesh and Slaven. Do you have any questions or comments for Ahmed?
I don't have any questions. Very nice.
And by the way, Mohammed said hello. I think he's from Yemen.
Mohammed Adahar, yes. He's from Iraq.
I think
he's from Iraq, but he done his residency in Yemen. He's one of my great mentors and friends. Now he's in USA.
Well, you know, it just seems like we have 3 or 4 people watching here, Ahmed, but we have at least 300 people watching your presentation online. At least, probably more, probably 400 or 500 watching what you just did. So thank you very much. Okay, Slaven or Rakesh and Amir, have any questions or comments?
I don't have any questions. Thank you for this nice presentation.
Amir, go ahead, Amir. Go ahead.
I say thanks for this nice presentation. Go ahead and be your best.
Thank you. These cases are done by Dr. Cherian, not by me. I just was observing, but I'm sharing my experience. And I really learned a lot just from observing.
Very good. Slaven or Rakesh, do you have any comments or questions for Ahmed? They're muted. Ahmed, were those pictures from the Bharatnagar OR? From the Nepal OR?
Yes, they are from the OR. I have a very advanced OT. It's like the dream for every neurosurgeon. Every facilities are there, cutting edge facilities. Very, very nice.
Oh, great! So you got to practice your anastomosis.
Yes, I practice in the lab with Dr. Cherian almost every day. Now we start with chicken wings, and the next stage will be in rats before we start applying on the theaters.
Okay. Well, Ipe, you're there. You're there, right, Ipe?
Dr. Ipe, is here?
Yeah. Thanks, Ahmed.
Yeah.
Thanks, Ahmed. We had over the last week we had a CP angle, a giant CP angle, a 5 centimeter CP angle, and then we had a giant craniopharyngioma, and then grade 3 AVM. So these were the last week's 3 major, and an aneurysm. Yeah, and an aneurysm, of course.
Yeah.
So, but these were the 3 major cases. So we had done. So Ahmed has been following and he's been showing, and you can see how we went ahead and took out these, did these cases. So there are any questions you can ask me. I was the chief operator in all these cases.
Well, I just want to say that the as far as we'd like to get involved within the OR, but I realize I don't expect you, and I've heard you say that you don't want to comment during surgery. I don't expect you to comment. I expect you to concentrate on your surgery, because obviously it takes 100% of your concentration. You can't be answering questions or talking. But we'll figure out some ideas on how we can incorporate televising it, possibly commenting after the surgery or discussing the case with an online community of neurosurgeons. But we'll figure out something.
Let me show you something, John.
Okay.
I'm going to screen share, and am I screen sharing now?
Not yet.
I'm screen. No, not yet. Okay, I'm going to screen share, and I'll show you how I'm going to televise this surgery. Oh, I can't. God, I can't, because this is a PSP server, and I can't. It doesn't allow me to screen share. But
Right.
I have something called the OR1 Neoprime. So it's in my office, and I can, if I screen share it, I can see everything. Microscope, endoscope, surgical cameras, from the lights, everything. I can see it in my screen, the same screen here.
Oh, okay.
And
Well, if you can see it, that means we can televise it.
Okay, yeah. So I will figure out some way that I can do. So in my room, I can see all the 3 theaters, all
Right.
the screens from microscope, endoscope. Even I can see it from the navigation screen. I can see it from the O-arm, intra-op, MR. Everything I can see here
Well,
with
it's
the
doable.
OR1 Neoprime.
Everything you see can be televised. Everything. It's just a matter of getting the right inputs and connecting the right wires. So we'll figure that out.
Any questions from the neurosurgeons?
Yeah, Rakesh, Slavin, or Amur, do you have any questions for Ahmed or Ipe?
No, I just wanted to
Go ahead,
thank
Slavin.
you for this presentation, and I really enjoyed it. So I have no questions. I think it is really good.
Okay, Slavin.
And,
Okay.
another
Thank you for coming.
Super Sunday. Thank you.
Thank you for coming. Amur, do you have any comments? Oh, you've already made a comment. I'm sorry. Okay. Okay, Rakesh, are you still there or no? You may have had to answer the call. Yeah, okay. Thank you very much for setting this up. And that was good, to figuring out that screen sharing on the fly there, using 2 computers, the technical wizardry. But, well, we'll talk later about how we can set it up. I think maybe get involved Sujit from World Link. He might know how to connect it.
Yeah. I will ask Uttam also to figure out.
Yeah, I'll be glad to work on it to set that up. But that's great. Okay, so to everyone out there, we're televising a meeting with the Sudan neurosurgeons. I'm going to talk about cisternostomy to a group of neurosurgeons, and we're going to try to get as many African neurosurgical residents as well as other residents around the world to watch. And that's Tuesday at 5:30 CET. I believe it's around 8:30 in India. But
it should be around 10:30 in India. It's
10:30, 5-hour difference.
It's 5:30 GMT.
Right. Okay. We'll be posting an article on Neurosurgical TV for that.
Yeah.
So, very good, gentlemen. Thank you for your time.
Thank you very much.
Thank you very much, guys.
Okay, we'll be
Thank you.
communicating.
Bye. Yeah. Thank you, John.